get us started. For those of you who don't know me, I'm Jeff Kahn. I'm director of the Bergman Institute of Bioethics, and it's my privilege to welcome you all to this Levi Leadership Symposium on containment. As you know, my role is to just welcome everyone and give you a tiny bit of background about the Levi Symposium, why we call it that, and its history, and then I'll turn it over to my friend and colleague Jeremy Green to introduce the program.
Jeff, a little louder.
Louder? Okay, maybe I'll use a lav. Thank you for letting me know. I can project, but I think I'll do it this way. Better? Okay. So my role is to welcome everyone, which I just did, and then give you all a very short background about the Levi Symposium, why we call it that, and what we hope to do with them, and then I will turn it over to my friend and colleague Jeremy Green to introduce the program. So the Robert H. Levi Leadership Program in Bioethics and Health Policy was established by a gift from the Levi family in 1997 in honor of the late Robert H. Levi, who was an alumnus of Johns Hopkins University and a member of its board of trustees and hospital, and he played a major role at both Johns Hopkins and to the Baltimore community for over 3 decades before he died in 1995. He was president of the Hecht Company department stores. Those of you who are from the Mid-Atlantic and are of the right age will remember was a real institution in Washington and Baltimore. And he was a civic leader and philanthropist. In addition to being instrumental in the revitalization of downtown Baltimore and serving on the boards of many Baltimore institutions, Mr. Levi was a patron of the arts who gave generously to the Baltimore Symphony Orchestra and the Baltimore Museum of Art. The city and Johns Hopkins benefited greatly from his extraordinary vision and deep personal commitment. The goal of the Robert H. Levi Leadership Program is to raise the level of ethical discourse about critical issues in medicine and social policy, both in the community and among those who have the practical responsibility for addressing them, through a public event on a current topic of importance to the nation, hence our gathering here today. And so we are honored to have the Levi name associated with these symposia, and while no members of the Levi family are with us in attendance today, they ask that I send their warm wishes, so that I do to you all. At this point, it's my pleasure to ask my friend and colleague Jeremy Green to come to the podium and introduce today's program. Thank you all for being here.
Thank you, Jeff. I'd like to also thank the Levi family and the number of people who've been involved in helping this symposium come together. It's really going to be I'm looking forward to a productive set of conversations across several different disciplines, which the Bergman Institute is known for bringing together around the subject of containment. Today's, I gotta be careful there. Today's event is, I think, a particular treat. We are launching into a broader discussion of how we think about the ethics, history, politics, and broader conversations of what it means to contain infectious disease in a post-genomic world with a really, a top-notch set of panelists to bring us back to the year 2014. I think our memory will be stretched further back than 2014. I hope, as a historian, that we can push our horizon past that. But if I take us back initially just to one day in 2014, to August 12th, in the midst of a rapidly unfolding Ebola epidemic in West Africa, the New York Times ran an article, some of you may recall, with a headline, "Using a Tactic Unseen in a Century, Countries Cordon Off Ebola-Wrecked Areas." And as the article's author, Donald McNeil Jr., continued to describe, quote, "The Ebola outbreak in West Africa is so out of control that governments there have revived a disease-fighting tactic not used in a century, the cordon sanitaire, in which a line is drawn around the infected area and no one is allowed out. Cordons," he continues, "common in the medieval era of the Black Death, have not been used since the border between Poland and Russia was closed in 1918 to stop typhus from spreading west. They have the potential to become brutal and inhumane." Now, some of you may also recall that 2 days later, the well-known author of the coming plague, among others, Laurie Garrett, responded in the New Republic that the cordon sanitaire was heartless but effective. Contesting McNeil's chronology, Garrett insisted that she had seen cordon sanitaires in her living memory in the 1990s and that they worked. The target was also Ebola. This takes us back to this earlier Ebola epidemic in Kitwit, Zaire in 1995, the outbreak which was more quickly contained. Garrett was there, she claims, when all plane flights in and out of Kitwit were shut down by the military, describing Mobutu's cordon sanitaire as, quote, brutally effective. She concluded that if similar cordon sanitaires had been imposed strategically across Sierra Leone, Liberia, and Guinea during the initial outbreak stages in the spring, we probably would not now be facing an epidemic that threatens to spread in the most populous nation on the African continent. And so even in these two very limited sources from 2 days apart in 1 week in August of 2014, we see an exchange which begins to capture in microcosm some of the problems of containment in infectious disease that are necessarily historical, that are also necessarily mired in different social positions and social contexts, and logics that can at once be deeply utilitarian and yet invoke changing deontological principles of who has a right to contain by force the nature or threat of infectious disease. Also begins to propose questions. Which diseases are met by logics of containment and which are not? Who gets to make these decisions and why? When force is justified? What new technologies as forms of containment change become involved in these contestations, and to what extent the politics do change or do remain the same in these contexts. These are just a few opening questions, and we will get into many more in today's panel. But it's really an honor to introduce our two panelists today, Kaci Hickox and Gregg Mitman. I'll introduce both panelists, and then Kaci Hickox will speak, and then Gregg Mitman will will speak subsequently, after which we'll have a screening of In the Shadow of Ebola, the film that Gregg Mitman produced, at which point we will then have a broad panel discussion. And I would ask you to, to the extent you can, hold on for all of this, because by the time we tie these questions together in discussion, I think there'll be a lot of meat there to flesh out. But to introduce our panelists, Kaci Hickox currently works for Médecins Sans Frontières, Doctors Without Borders in Amsterdam as their infection prevention and control advisor. Kaci became an emergency department nurse in 2002. She received a diploma in tropical nursing from the London School of Hygiene and Tropical Medicine in 2006 and joined MSF in 2007. And for MSF, she worked as a nurse manager for primary care and outbreak responses in Burma, Nigeria, Sudan, and Uganda. She obtained her MSN and MPH from Johns Hopkins University in 2011, and then completed the CDC's Epidemic Intelligence Service in 2014. After joining MSF's efforts to fight the West African Ebola outbreak in 2014, she returned to the U.S. and further fought for an ethical public health response to Ebola after herself being forced into an isolation tent in New Jersey and then home quarantined in Maine. Gregg Mitman is the Willis Research and William Coleman Professor of History, Medical History, and Environmental Studies at the University of Wisconsin-Madison, an award-winning author, filmmaker, and teacher. His interests span the history of science, medicine, and the environment in the United States and the world. Past president of the American Society for Environmental History, he is the recipient of fellowships from the Alexander von Humboldt Foundation, Carnegie Corporation of New York, and the Johannes Guggenheim Memorial Foundation, among others. His recent works include Future Remains, A Cabinet of Curiosities for the Anthropocene, Breathing Space, How Allergies Shape Our Lives and Landscapes, and Real Nature, America's Romance with Wildlife on Film. And together with Sarita Siegel, he co-produced and co-directed two films of particular interest to today's event. The first, In the Shadow of Ebola, an intimate portrait of the Ebola outbreak in Liberia, and The Land Beneath Our Feet, a documentary on history, memory, and land rights in Liberia. And he's currently completing a book, The World That Firestone Built, on the impact and legacy of the Firestone Plantations Company in Liberia, to be published by the New Press. So we're in for a treat today. Please join me first in welcoming Kaci Hickox to be our first speaker.
I was telling a friend in Amsterdam before coming here today that there aren't a whole lot of perks to being the Ebola nurse, but getting to come back to Hopkins and be here at this campus and see this beautiful city that I really grew to love is definitely one of them. And when I think about what I can add to this conversation about infectious disease outbreak response and ethics and quarantine, you know, I'm not an expert in any of these things, but I can tell you a personal story first about Ebola in Sierra Leone and what it looked like to treat Ebola patients there, and then what it felt like to actually be isolated and quarantined when I returned. I didn't try this out before we started. Here we go. Okay, sorry. So this is a picture of the Ebola treatment unit in Sierra Leone. I arrived there in September of 2014, and the treatment unit was opened just a couple of days before I arrived. These three large white tents that you see, those are the tents where patients would be cared for. One tent was only for patients that were being tested, so they weren't confirmed yet. The final tent was for confirmed patients and held 32 patients, so it was a 32-bed Ebola treatment center. And I want you to just imagine, it was my second day there, and I had learned how to don the PPE, and I went into the Ebola treatment unit, and the very first time you go in, they literally sort of just give you a tour. It's maybe 20 minutes. You don't even touch or take care of a patient, because really your partner and your buddy that is with you who's experienced in going to that treatment unit is just teaching you how to be super aware of everything you do and everything you see and everything you touch, and to understand how to get in and out safely. But it was just a few hours after I had gone in for the first time that I was sitting across from a young girl. She was maybe 19, and I asked her, you know, how many, has anyone in your family been sick with Ebola? Because that's, of course, one of the screening questions. We want to know if there's been contact with an Ebola patient and if our patient in front of us has any risk factors. What we don't want to do is put a patient that has no risk into the treatment unit and test them and put them at risk by putting them with possible Ebola patients. And she responded to me and said that 17 of her family members had died of Ebola in the past months. And that was really the moment that it hit me. The complete destroying of families and communities in such a rapid way that this disease causes. This is a little girl. I've marked out her face for her own patient privacy, because obviously when I took this picture I didn't get her approval, unfortunately. But she was 4 years old and had spent 4 days in a testing center after her mom had tested positive for Ebola with her mom. And she, of course, developed a fever a few days later. And we admitted her, and thankfully she survived, she tested negative, and her mom survived Ebola, and about 3 weeks after this picture was taken, she was reunited with her mom, and it was one of the most amazing days that I had in Sierra Leone. These are just some pictures of the Ebola treatment unit and what it looks like. It's very different, obviously, than any hospital in the U.S. or here in Baltimore. All of these healthcare workers to the left on this picture, they were just water and sanitation workers. It takes that many people to mix chlorine and go into the unit and clean surfaces and take out bodily fluids. And they unfortunately had the most hard job of putting patients that did not survive, putting their bodies into a body bag and taking them to the morgue so that their bodies could be disposed of in a safe way. These are just some pictures of what the patient area looks like. So again, this would be a patient tent, this white tent here to the left. And you can kind of see the inside of the tent. It's really just a concrete floor, basic beds, lots of plastic fences that separate different areas so that we make sure staff and patient flow protects everyone from transmission of disease. And I know you've all seen pictures of the full body PPE that is still being used in the DRC Ebola outbreak today. People are always really interested in how the PPE is taken off, how the doffing process happens. So this is just a picture of what that looks like. Basically, we have sprayers that spray a strong chlorine solution from your neck down, so that if you have any Ebola virus on you, it gets destroyed before you even start taking that PPE off. And this is what the family-patient meeting area looks like. I'm going to show you a picture of what the tent that I was in New Jersey looks like. But even for Ebola patients in West Africa, MSF long ago, we've been dealing with this disease for over 40 years, realized that you have to find a way to connect patients with their families even while they're being isolated and treated. And this is what that looks like. It's just an open air area, a double fence to make sure that we're keeping the minimum of 2 meters distance so no body fluids mix. But many patients, as they were getting better, but their viral loads were still too high to send them home, so they were still infectious. This is how they would sit outside and actually be able to connect and laugh with their families. And then this is what it looks like to bring a patient out of that Ebola treatment unit. They're in the Ebola treatment unit. It possibly has Ebola virus on surfaces, and inside they have it on their clothes, on their bodies. So how do we get them out in a safe way? And there's basically an open door on the inside where positive patients are, and to the outside of the low-risk area. And the patient would wash off with soap and water, and then chlorine water, and then soap and water again, and chlorine water again, and come outside. And then there would be the most amazing celebration. I mean, incredible singing and laughing, and you can look up a couple of YouTube videos of that. It's really powerful. So then I'm going to just briefly get through the boring stuff of what the laws are, what the rules are. Basically, states have 3 ways that they can quarantine someone. The first being voluntary quarantine. So this is kind of when a local or public health department tells a person, well, we want you to stay home for 2 weeks because your kid has, possibly been exposed to a patient with maybe pertussis in their school. So you can just ask the person or the person that was exposed, please stay home. Nothing is documented, nothing is written down. Oftentimes there's definitely a power dynamic between public health saying, we would like to ask you to stay home, and the patient saying, well, I guess I have to. It's the health department, right? The other option is a public health quarantine order. So in some states, public health officials can make an actual official quarantine order, but that order doesn't go to the court. So the person still doesn't have really opportunity to argue their case or have due process. And the final is a court order for quarantine, and this is when the health department can say, okay, this person needs to be quarantined, but we're going to go to a judge to actually put in that order. Oftentimes there's some wiggle room about how much time the public health department has to put in that order and how much time the judge has to actually review the order. But that's just a little bit of the housekeeping. And then these are some of the things that experts in quarantine law say we need to be thinking about. We're balancing public health versus individual rights. And what does that look like? Well, it looks like the gravity of harm. So what kind of disease is this? In Ebola, that is definitely something we think a lot about, right? In the current outbreak, I think the fatality rate is over 60% in the DRC. It was right around 50% in the outbreak in Sierra Leone. So it's definitely a disease that has a lot of harm. Means of transmission is another thing. So again, for Ebola, that is contact with blood or body fluids. For other diseases, they can be droplet or airborne. Effectiveness of transmission. So again, with one case, how many other people could they infect when they're in that infectious period? And then what are the measures that we can do to prevent transmission? What does that look like? Is it social distancing? Is it quarantine? Is it vaccination, behavior change, contact tracing? And on the individual rights side of things, we're looking at the gravity of intrusion of rights, the duration of intrusion. So again, for Ebola, it's all about the incubation period, so that 21-day, 3-week period, the effectiveness of the measure, and one of the key principles is that we should really be using the least restrictive effective means. So now I have left Sierra Leone and I'm returning back to the States. And I can tell you that I spoke with my mom and friends, and they all said, you know, what do you want when you come back? And I said, oh, I just want a piece of pizza and to sit on my couch with my partner at that time, my now husband Ted, and I just want to rest. And that is not what I got to do when I arrived back. But to remind you of the timeline, Thomas Eric Duncan was basically kind of diagnosed and died of Ebola in Dallas in late September. And then unfortunately we had Nina Pham and Amber Vinson develop Ebola in mid-October in Dallas after their contact of taking care of him. Then Craig Spencer, who returned back from Guinea treating patients, developed a fever and was diagnosed with Ebola on October 23rd, and my flight flew back into Newark Airport on October 24th. Talk about bad luck. One of the things that Governor Christie and Cuomo said time and time again was, we are doing this out of an abundance of caution. And this is what an abundance of caution looks like. It's a tent out in the middle of basically an empty building in New Jersey. The thing about quarantine is it is so isolating, and when it isn't done because it has to be, when it's not the least restrictive effective means, it really does have individual and family consequences. In New Jersey, the statutes did not require New Jersey to get a court order to go to court so that I could argue my case in front of a judge. It was only because I found a really good civil rights lawyer that I believe they released me after 3 days in that tent. I think if I had not, I just don't know how long I would have been in the tent. And in those initial sort of 24, 48 hours, even though I had tested negative, I had no signs of Ebola, I didn't get any clear answers from health department officials in New Jersey about when I would be released. And on top of that, you can see, this is my lawyer, Norman Siegel here. He was allowed to come see me after fighting to come see me. They really only wanted him to talk to me on the phone. They didn't want to allow him into the facility. You can see that I'm in a tent, right? He's on the outside of a plastic window. And this is how the healthcare workers would talk to me. They would stand on the outside of the plastic window and we would talk. And I said one day, it was early Saturday morning after being there around 7 p.m. on Friday, I said, can my partner Ted come see me? Healthcare workers are right outside of this window, and all I wanted at that moment was to know that he was right there in front of me, that I could look into his eyes. And the doctor that was taking care of me, who was standing outside of that window, said, no, it's up to the New Jersey Health Department to decide if you can have visitors or not, and they have told us that you're not allowed to have any visitors. So this is what it looks like when we allow politics to intervene, when we allow politics to trump science and to trump public health. So Christy did let me out of the tent, and then I went to Maine. Unfortunately, things didn't get too much better in Maine. I was asked to voluntarily stay at home and be in home quarantine in Maine. And what that partially looked like is when Ted and I arrived at our house in Maine, this was our house with our cars in front of it, this state trooper car was parked there. And Ted walks up to the state trooper. I walked straight into the house. I didn't want anything to do with it. But Ted says, what what's going on? Why are you here? And the state trooper actually said, well, we're here for your protection. And said, but is that really true? Like, you know, if Casey wants to leave the house, is that okay? And he said, yes, we're just here for your protection. But this is what the statutes state in Maine, that a court order for quarantine can be placed by the health department, and a hearing must take place within 48 hours of detention. This is the most important thing if you don't remember anything else from today. For me, this is the most important thing. This is what protects due process rights and prevents political overreach. So what does a bike ride have to do with that? It's such a weird thing, this bike ride that was literally on, you know, most of the front pages of the paper the next day after my husband and I went on this bike ride. And I think so many people didn't understand that I had to leave the house because otherwise the state of Maine was going to just wait until my monitoring period was over and expect me to stay home. They did not want to go through the process of this court order. So we forced them to do that by leaving the house. And the great thing is the court system really can protect individuals. The judge in Maine ruled in my favor. And this is basically what he said, that the state has not met its burden of proof at this time to provide clear and convincing evidence that limiting my movements to the degree requested was necessary to protect the public health. So it's the court system doing its job, being able to do its job. And just some examples of what more politics instead of public health looks like. I mean, you know, talk about risk communication and leadership. Governor Christie said, well, we don't know what we don't know about Ebola, which is maybe true, but we've been dealing with outbreaks of this disease for 40 years. Doctors Without Borders specifically is really the expert in how to treat and manage Ebola patients and Ebola outbreaks. Governor LePage, after the judge ruled in my favor, said, well, I still don't trust her. There was no reason for him to make that statement. From day one, I had said, of course, I'm willing to be monitored. I'm willing to do all the things that are truly necessary to protect public health, but home quarantine is not one of those. Governor Christie, when I was in the tent, made the statement that I was obviously ill, which was honestly one of the turning points for me when I thought, okay, you know, I have no power, and my mom is calling me on the phone in tears saying, are you really ill? Governor Christie is saying you're sick. My mom is hearing this on the TV. And Governor LePage saying, I want her to prove she doesn't have Ebola. Well, I had already had a test for Ebola. I had no symptoms. You know, what else was I supposed to do to prove to him? Just a reminder, it wasn't just Maine and New Jersey. Those were my very personal experiences, but there were 23 states with more restrictive policies than the CDC recommended. And I'm going to speed through these. I don't actually know exactly what time I started.
We can give a few more minutes.
Okay. This Yale ACLU report is one of my favorite reports about the Ebola outbreak. If you haven't read it and you're interested in this subject, I really highly recommend it. But you know, again, reflecting on what leadership looks like, I think during the midterm elections in 2014, you can see this is just a map of the, a graph of the Google analysis, how many people Googled Ebola. And you can see that it was really directly linked with those midterm elections. And in Canada in 2003, if you'll remember the SARS outbreak, there was specifically one wave of the outbreak in which 70, 80 cases were related to one hospital in Toronto, and 40% of the cases were healthcare workers. And this was a study done after the outbreak where they were just asking Canadians who had been quarantined. There were about 15,000 quarantined during this time. And they said, where did you get your information? And these were some of their sources. I really love that 54% was from the media. That's kind of very scary to me. These are people that were actively quarantined, and 54% of them got their information from the media. 30% said they received inadequate information about their quarantine. And healthcare worker status, so if they were a healthcare worker who was quarantined, did not significantly influence whether they thought they received adequate information. Even the healthcare workers that were quarantined didn't feel like they were given the communication they needed to really understand what was happening. It also, many of them said it caused PTSD and depression. But the main thing I just want to remind you is that, if quarantine isn't done well, it's not going to work. So if we decide to do something as drastic as quarantine, we need to do it very well. And then there are just ripple effects. There was, the girl that had traveled to Nigeria who didn't have Ebola at the time, and her school banned her from school for 3 weeks. There was a teacher who was in Dallas at the same time that Thomas Eric Duncan was diagnosed, nowhere near Thomas Eric Duncan likely, but she was also asked to stay home for 3 weeks. There were Nigerian students that were denied their application to a university, and Liberians in New York and Long Island who were told not to come to work. And then there were the Bellevue employees who were taking care of Craig Spencer, who this woman said she went to her local beautician, and when the beautician said, "Wait, you work at Bellevue?" she backed away from her and didn't want to cut her hair because she wanted to first know if that woman had been anywhere near Craig Spencer. My lawyer was even, some members of his gym went to his gym and complained and said that they didn't want him to be allowed in the gym. And you can see that he obviously had contact with me when he saw me in the tent. And my partner was banned from his nursing school campus. I also received some really interesting mail.
Oh my gosh.
And I used to blur out the bad words, but I don't really think that's fair. I mean, this was sent to me. And this is the kind of hate that bad policies and that politicians who are manipulating the population drives. I will say there's also leadership, and that's what we need more of, and that's what I will implore of all of you, that when you have the chance to use your voice, when you have your chance to write an op-ed or to explain to someone why something is scary and wrong and to give them the facts, then I hope that you'll stand up and do that, because it really does make a difference. And even this school, Johns Hopkins, really supported me, and I was so thankful for that support. Quickly, the CDC had risk categories. I fit into the some risk category because I had treated Ebola patients in PPE. But in their guidelines, they sort of have this caveat that says, based on specific assessment of the individual's situation, you could put in more restrictions. So, they had this guideline, and they basically said, no, we don't think healthcare workers should automatically be quarantined. But then there was just this confusing language. And if you look at the European CDC guidelines, there's no term risk, right? It's a type of exposure. We're not using the word risk, which is just a much better use of risk communication. And anyone that would have been in my category, it just says active monitoring. Simple and clear. No further assessment, no confusing language. And the most important thing is that all of these things distracted from what we should have been focusing on, which was responding to the outbreak in West Africa and protecting healthcare workers that would end up treating patients. The only two people that contracted Ebola on U.S. soil were two nurses. I couldn't have a talk like this without just reminding us that if the health systems in West Africa had been stronger, then the outbreak could have been handled better. So without addressing health inequity, we can't expect that we're going to really be able to respond to and prevent global infectious disease outbreaks. Today in DRC, there have been over 800 cases and 500 deaths. And I don't know if you've heard, but recently there have been attacks on several Ebola treatment units. Cars burned on fire, part of the buildings burned, militia groups coming with guns. And I love what Dr. Joanne Liu, the MSF International President, has said, just reminding us that we can't allow militarization of an infectious disease outbreak response. It doesn't work, and it puts everyone at risk. All right, so what can we do better? And then I'm wrapping it up. I really think we need to invest in global systems to reduce those health inequalities, right? I mean, we have to invest in public health around the world. We need a strong response to outbreaks at their source. We need public health leadership, clear risk communication, science-based policies, and finally, quarantine statutes that protect due process rights of individuals and really make sure that politicians don't get to make decisions that are not based on science. And more than anything, I think we need to learn to listen to each other. I mean, has anyone thought about asking healthcare workers returning from West Africa how they felt and what they were afraid of? And what they needed to feel safe, how they would report if they had a fever, and what would happen. You know, if we had sat down and talked to people and said, what can we do to make sure that you and your family are confident that no matter what happens in the next 21 days while you're being monitored, you're taken care of. And this is my team in Bo, Sierra Leone. They sent this picture to me, which they took, one of my colleagues took it from the top of a water tower. And when I received this picture in an email, I just started to cry with my husband and said, you know, we shouldn't be focusing on West Africa right now. We shouldn't be focusing on me in Maine or New Jersey. But I think more than anything, a good infectious disease response takes us listening to each other and standing to fight a disease together.
Thank you so much, Kaci. There are so few people who can speak with as clear a voice as you can about the human consequences of broader state-based public interventions on containing disease. And part of this has to do with having been in the place you were at the time you were, as you mentioned, landing in Newark Airport on that particular day. I think that our next speaker, Gregg Mitman, is able to provide a different level of human context in terms of understanding containment and Ebola, partly from being where you were, Gregg, at a particular time and place, and having both the tools and the strategies of documentary filmmaking as part of repertoire you're developing. So please join me in welcoming Gregg Mitman for a discussion and then for a film. Thanks.
Thanks so much, Kaci, and I also want to thank Graham Mooney and Rebecca Wilbanks for inviting me for the symposium, Suzanne Caesar for all the background legwork she did in getting me here. It's a real pleasure to be here. And the film that I'm going to show is 26 minutes in length, and I just want to provide a little bit of context for it. I think there'll be a lot of resonance is what Kaci has had to say. I was in Liberia in June of 2014, really at the beginning of the outbreak. I was in Monrovia in June when the first 2 Liberian deaths in the city, in Monrovia, in Redemption Hospital occurred. I had, there was, at that time, there was very little news coverage, and I had been planning the trip since March. There was very little CDC information. I contacted a colleague of mine that works on hemorrhagic fevers in Africa. I said, oh, no need to be concerned, Greg. So we were there. I had been traveling to Liberia for 2 years, following an itinerary, retracing the path of a Harvard medical expedition to Liberia that was there in 1926 on behalf of Firestone Tire and Rubber Company, which at the time had just gotten access to up to 1 million acres of land in Liberia to grow American rubber. And it developed into what would become the largest contiguous rubber plantation in the world. The importance of that I'll come back to in a minute. So I was there with my film crew, some of whom are Liberian, and there in June. Returned in July and was quite upset by the media coverage that I saw beginning to appear. So the first story that came out of the New York Times on the Ebola outbreak in West Africa was the irrationality and superstition of West Africans for attacking international healthcare workers. And then when 2 Samaritan's Purse healthcare workers, Camp Brantley and Nancy Ripple, were airlifted from Liberia at the end of July, who had been infected with Ebola, and were brought to the U.S. for treatment, the Twitter universe just exploded. Including, and as Kaci had this tweet up from our current president: "Stop all flights from Ebola-infected countries. The plague will spread inside our borders." In that panic and fear in the news coverage that was happening, we were hearing little from Liberians or Sierra Leoneans or Guineans themselves about how their healthcare workers, local communities were responding to the outbreak on the ground. Much of the attention was focused on the heroism of white healthcare workers going to West Africa. Meanwhile, many West African healthcare workers had been dying, as well as obviously populations there. And all of this news coverage really, which was focused a lot on the kind of irrationality and fear and superstition of West Africans, failed to grasp or failed to look at why some of these reactions might have been happening. What was the historical circumstances or the cultural circumstances that may have produced the way people were responding on the ground. One of those contexts, in the context of Liberia, is that Liberia has long been a laboratory for American biomedical research. So this Harvard expedition that I mentioned, they were doing a complete epidemiological and biological survey of Liberia on behalf of Firestone that needed a healthy labor force. They were testing experimental drugs for schistosomiasis and trypanosomiasis on Liberian populations in the 1920s. The Firestone plantations themselves became an active site for biomedical research. There was a lot of work done on testing of experimental drugs for malaria control and treatment on the plantations in the 1930s and 40s. Then, when Firestone established the Liberian Institute of Biomedical Research, which was a facility that for American biomedical research, there's, and I heard conspiracy theories in Liberia about how at this institution they were purposefully infecting Liberians with malaria during the 1950s, and I thought at the time it was conspiracy, but every time a Liberian has pointed me to a conspiracy theory, there's always been elements of truth in it. And a couple of years later, I was in the WHO archives and indeed found documentation of that. Then in the 1970s, the New York Blood Center established BiLab, which was doing a lot of experimental research on hepatitis B and vaccine development. So when the Ebola outbreak erupted, and one of the #1 news stories within the Liberian daily papers was that it was likely introduced by the American military, who had introduced it to test a vaccine on the Liberian population. Within that larger historical context, it does not seem so irrational, given the kinds of encounters and experiences that Liberians have had over their long history in terms of dealing with American medical researchers. And the international response really initially, MSF obviously different here, but in terms of some of the international response, what did the U.S. do? We sent troops, right? And if you know anything about Liberia, the least trusted institutions in Liberia are the state and the Liberian military. So if you're trying to build trust, you need to find places where there are trust leaders, right? And really in terms of dealing with the epidemic. And so as a result of this kind of context, in July, our team of Liberians and myself, and then my filmmaker partner Sarita Sigel, who was based in the UK, collectively decided that we were going to follow Liberian voices and perspectives on the ground. Without any, at the time, we weren't sure where it was going to go, but we just knew that we needed to be documenting this because no one else seemed to be. And I sent a camera to our Liberian cinematographer, Alex Wiapla, who's the most talented the most talented videographer in Liberia. He began just following what he could on the ground. We began following stories in the US of Liberians that were being affected by the outbreak. And then in October, I sent a sample reel to PBS Independent Lens of material we had gathered. They green-lighted production. They wanted it very quickly. They wanted it in 6 weeks, which, in journalism, that's a fast turnaround. In the documentary world, that's like crazy. And they had partnered with the Washington Post that was going to do, they were going to do release it on the Washington Post. And while we had no idea where the story was going, I was teaching a class on environment and health and global perspective, had a lot of students in the class, many of whom had international health experience. We were kind of living through the outbreak together. Some of the directorial decisions that were made in the film were based on their kinds of reactions, like, oh, of course there should be a travel ban, or, yeah, maybe we should consider quarantines. And I'm like, do you know what a quarantine really looks like, right? How are travel bans affecting people around you in your community? That might be, for example, Liberians. And so we ended up producing this. We were done by December, and this really corresponds with what Kaci was pointing in terms of media coverage. By the time we delivered it to the Washington Post, they said, oh, it's no longer news, we're not interested. And so it gives you a sense of those kind of cycles of news and epidemics. I want to thank our team, Alex Wiapla, our Liberian cinematographer, my co-director, co-producer, Sarita Sigel. Particularly, I want to express our heartfelt thanks to the Yuri family, who allowed us to immerse ourselves in their lives during a really very emotionally traumatic time, and you'll see why. And not only for this film, but for another film we made that Jerry mentioned, The Land Beneath Our Feet. as well as Hipco musicians that we worked with in the soundtrack. I will say there's a very graphic scene in the film, and there's viewer discretion advised. You may want to turn your head away during that time. I'm happy to talk about it afterwards, why we included that scene. We had lots of discussions with it among our Liberian team, with PBS Independent Lens, and ultimately we decided to include it. But if people want to talk about the ethics of that and so forth afterwards, I'm happy to do so. So without further ado, I'll just, can you bring the lights down?
That was a powerful film, Greg, and it can take a moment for us to collect our words for them. But we have about 20 minutes or so for discussion, and I'm happy to field questions. Are both of your mics working?
Can I just say one thing about the version that you've seen is the director's cut version. The version that's on PBS Independent Lens online has a different ending. They didn't want it tied up with U.S. politics around travel bans and so forth, so the return of Nellie is not in the film. It makes no sense to us, but since they were paying for the production, we had to kind of abide by them. So whenever I get to show the film, I show the director's cut.
Well, let me field questions. So, Randy, if you'll start us off, I might reduce you to one mic so there's not a feedback. Sure.
So, Greg, I think this is the third time I've seen this. I don't know if I've seen both cuts or not. It's a very powerful film. But I want to ask you about the way in which it presents among the Liberian people and the Liberian government as victims. And my understanding is that there was a lot going on in these communities of self-help and trying to deal with the issue. And people putting on plastic suits and reporting people carrying bodies, a whole bunch of things.
Right.
I've also heard from people who worked in the Department of Health and came and talked to the School of Public Health about what was going on in terms of collecting epidemiological information. So that story isn't here, and I wonder if you could say more about that, because as far as it ends, it's sort of like everything's a mess, and then MSF shows up.
Yeah, I can speak to that. I mean, that certainly wasn't the intention. I can see how that film is, the film can be read that way. But, you know, part of our, like, why we included DJ Blue, who's the most famous DJ person in Liberia, and, you know, the turn where there was starting to be mobilization on the ground among community members, that was the intent. As I said, we didn't have much time to make this film, and so, you know, if I were to, sorry, if I were, you know, if I had the time to,
I wonder if we might.
can we just use the lab?
This one's off, yeah.
No, but can we just
Oh,
use
yeah,
the lab?
looks that's good.
You know, I certainly, we would have brought more of that into the story, absolutely. And that's certainly how it was intended. But, you know, you make a film and then it gets out in the world and you see how, you know, some people, you know, so I know that some people take away the message from this film that, you know, the international community came in and saved the day, which is not what we want. And it's why, in fact, in the title card at the end, it says that the epidemic started to drop in October 2014, a month before the international community started arriving, right? But it's very subtle, and so, yeah, I agree, you know, with your critique in terms of it's one way how it could be read. When the film is now used by the CDC for its training of epidemic intelligence service. And they don't read it that way. I mean, they do see it in terms of its community mobilization, because I talked to a number of CDC officers that were stationed in Monrovia at the same time that we were filming, and they said, we didn't see any of this going on because we were up here in terms of the local community response.
Excuse me, this question is for Kaci Hickox. So part of what makes your story so moving is what appears to be a degree of insensitivity to the impact on your personal life, on quarantine that seems unnecessary, and actually unnecessarily disruptive of personal life. So my question is, I have two questions. One is, you said you've been tested, right? How reliable is that test, and how often was it repeated, and so on? So those are the scientific questions. But the real question is, what would it have taken to make conditions good enough for you and the people who cared about you so that you would have been willing to cooperate with the quarantine demands? Obviously not what was offered.
Sure. I wish that I, at this point, remembered the sort of sensitivity and specificity of the test. I can't give you specifics on that, but you know, it was a similar test that we used to test patients in West Africa. Typically, more because the test becomes more accurate the longer someone has symptoms. Their viral load in their blood is high enough that then the test is accurate. So we typically test twice, once and then 48 to 72 hours later. Because I didn't have symptoms, they only took one blood test from me and then not a second blood test. So that first blood test was negative. I don't really understand exactly how it worked, but I think it was, you know, maybe tested in one location and then also verified by the CDC. And I mean,
that already seems a misfire of what might be ideal procedures, right?
Yeah, you know, I maybe some of you remember, it's not something I go into detail because it's kind of, there's just a lot of kind of information that goes into it, but they did a non-touch forehead thermometer reading, basically temperature reading of me in the airport after I'd, you know, traveled for a long distance and been questioned for 4 or 5 hours in the airport, and it did show an elevated temperature. But once I got to the tent, the healthcare workers took an oral thermometer reading, which was normal. And, you know, the basically state health department decided to continue forward with testing me for Ebola, even though I did not have a fever. I think the fact that, you know, we do know a lot about Ebola. We know the longer you have symptoms, the, you know, more you become infectious. We have now, you know, some really good examples of that. Craig Spencer's fiance, who he lived with, didn't develop Ebola. Thomas Eric Duncan's family, even though he actually was home for multiple days with symptoms, didn't develop Ebola. You know, we know how Ebola is spread. Influenza actually has pre-symptomatic spreading, so you are shedding virus 24 hours before you start developing those flu symptoms. And Ebola is just not that way. So I truly don't think quarantine for Ebola in a U.S. setting makes sense. For a disease that we would need to quarantine, I completely agree. Sometimes there will be good public health reasons. But, you know, we highlighted on some, and your film definitely highlighted on a lot more. It has to be implemented so well. You know, for me, things as simple as making sure it's a comfortable space and allowing family to also be there, you know, depending on the disease. Also, one of the pre-reading for the symposium tomorrow, which I don't know how many of you are attending, but talked about the Johns Hopkins biocontainment unit and how it doesn't really have a place for the family and the patient to see each other. And like I mentioned, you know, in that tent, it would have been completely safe for my parents or my husband to at least stand on the other side of that window, and just knowing that they were present and right there in front of me, I didn't need to touch them. That would have meant the world to me. So I think those are just the little things. You know, it's nothing big. People, I guess in the media talked about how I was in a tent and there was a, you know, kind of a pit latrine type thing. I didn't care about any of those things. None of those things mattered. I wanted more than anything to see my partner.
Would compensation have made a difference?
You know, I was being paid by Doctors Without Borders for 3 weeks after I returned from the States. So the organization was, I mean, you know, it's a simple field salary, but
Of course, I'm thinking about it as a general issue for...
absolutely, yeah. A lot of people have talked about how that's really an important, also thing to think about.
Yeah. Sorry, I guess I just wanted, is that on? I guess not necessarily in contrast to the previous comment, but I left your film and certainly left your story with the importance of hearing about, and in the case of the film, really seeing what it looks like. I mean, I guess to say, as someone who's traveled overseas and understands a bit about what it looks like to provide healthcare in some of these settings for students or just regular old citizens to have that visual understanding of what it's like in these places. And I enjoyed, though again, it's just a story that you have a family involved, right? That to me makes it that much more relatable from a U.S. Perspective. And so I mean, I know you can't do everything in one film, but appreciate that bringing that personal connection.
Yeah, it's I can say students in the class when I was teaching it who were supportive of travel bans, once they saw and realized that there was a student in their midst and how it was impacting them, it completely made them rethink what a travel ban means and how it was actually impacting, you know, the Liberian diaspora community in Madison. So that personal connection is really important. I will say, just, you know, opposite your experience, so when Nellie arrived in Wisconsin, we got a call from the school nurse, and they wanted to integrate him immediately into the school system as a kind of, you know, an affirmation that of the kind of, you know, pushing back against the fear and panic. And we collectively said we thought it was a bad idea because if anything had happened, the kind of stigmatization and hostility that would have been leveled at the Urey family for allowing, you know, their child. So that's why there was the family themselves just volunteered to self-isolate. But actually the school district was willing to admit him right in, which is pretty amazing.
Yeah, so my name's Nancy Connell. I'm a recent, I just came to Hopkins from Newark, New Jersey, where I was in the Department of Medicine in the Division of Infectious Disease, and so I apologize for our helplessness in the face of what happened in our parking lot. Okay, so, you know, Dr. Christie was, you know, busy down in Trenton, you know, running basically our program, and it was pretty awful. So, but I'm struck by two different kinds of quarantine here. One is, you know, three really, but the quarantine that was imposed on you. And then that little tiny sentence in your film, self-quarantine at the end. So during the 2014 outbreak, in Newark, the Liberian community, which is enormous, it's thousands in Newark, it happens to be a hub, contacted various members of the Department of Health and the Department of Preventive Medicine and so forth, some of the folks in ID, infectious disease, and we had a big meeting, a community meeting, and they told us the story that when anyone comes from Liberia, they're met at the airport by a family who then brings them to their house, leaves them, turns over their apartment, and feeds them twice a day and helps them check their temperatures, and after 21 days, they enter society. So the concept of, you know, self-quarantine was very striking at the end. It was just a little tiny sentence, but I think it's one of the most important things, you know, vis-a-vis the comment here earlier about victimization, you know, taking care of your own experience. So Thanks, I have no question, just a comment. And another apology. It was
I don't know about Sierra Leone, but I can say in Liberia, in rural communities, they did the same thing with strangers. So, which was actually so they actually, excuse me, activated community responses, excuse me, that they had used during the war with strangers. And so strangers that came into the community were just self-isolated for 21 days, in a hut. They were fed, but that was, and it was really interesting that they were really relying on memories of how they handled people during the war that were suspicious.
Hi, my name is Divya Hosangani. I'm an analyst at the Center for Health Security, and I just want to thank you both for all the contributions you have made, both during the Ebola response and afterwards. One of the projects that I'm working on right now is with my colleagues is actually assessing Twitter data and Twitter activity during that very enormous peak that you highlighted in your presentation. So it's really interesting to hear your thoughts. And one of the things we've been observing in our data set and that we've been hearing in publications is how public health response can be politicized, and I think how social media can play a role in that politicization. And so, you can see this both, the Ebola 2014 response is a very present example of that, but then also even in the anti-vaccine movement or pro-vaccine movement, you can see there were publications talking about how Russian trolls actually hijacked that conversation and used it for political purposes. So I wanted to ask you for any insights you may have on ways to kind of combat the having public health response be interfered with politics. And also during the 2014 response, do you have any thoughts on what public health could have done differently or could have done better maybe to help quell some of the paranoia and some of the panic and the political rhetoric that resulted from the outbreak?
Wow, those are some loaded questions. I think a lot of people are analyzing and trying to find the right answer to all of the things you're talking about. In today's world where fake news or false information can just as easily spread, it's really difficult. But I do think having institutions like this one and the CDC and the New England Journal of Medicine quickly published something, basically saying that the states that were quarantining, were really not doing the right thing. I think having that, scientific medicine leadership is really important. As far as how to sort of separate public health from politics, we have the perfect example that even the CDC, I know people from the CDC who say that interim guidance on monitoring of people returning from West Africa was filled with, very interesting debates and, political opinions were definitely going into how it was written, the wording used. So somehow the CDC needs to be more neutral, right? We really do in some way, I think at a very high level, need to find a way to protect it from the politics. And I don't know exactly. I'm sure there are other experts who could help us work out what that might look like, but it definitely needs to happen. And the only other thing I can say is there are a lot of experts in risk communication. We really need to get those people on board. I think in public health and in even medicine, we kind of have been slow on the uptake on social media, and so we really need to get in gear find ways to use information and innovate so that we can compete with some of these other organizations. Do you have thoughts?
Yeah, I would just say that, seeking out who really are the communicators and trusted communicators in communities. So, for example, in Liberia, hip-hop musicians, radio DJs, artists are really trusted, by people on the ground. And you saw, hip-hop musicians coming together, doing songs, making videos. Within the U.S., the Liberian diaspora community, a friend of mine, Shawana Solomon, did this video that went viral that said, "We are Liberians, we are not a virus," and to really starting to to push back and challenge the kind of mainstream coverage that was happening. And if someone had asked me at the time in terms of well, what would you recommend Obama do, I would have said, fund the artists and musicians in Liberia in terms of getting the word out. Don't send troops, right? Because most of those ETU units that were built by the U.S. were never even used. And the amount of money that could have been spent in terms of really getting the messaging out in Liberia by funding those kinds of communities. And they were already doing it themselves, but it was really important.
Okay, my question is for Kaci. So I'm Michelle Lewis, I'm on faculty at Berman. And first of all, I appreciate your work and your sacrifice. From what I've heard and know about your story, it seems like a lot of your thoughts about this turned on your views of not having due process. My question for you is, and you may or may not have already thought about this, if you could go back in time or look at it now, what if you did have a fever? So what if you had a cold and you had a fever from a URI? How would that change your thoughts?
Sure. Talking about kind of misplaced resources. In the U.S., there were the 5 airports where 90% of flights were returning from the 3 countries affected by Ebola, that a screening was put in place, right? And when I arrived, I self-disclosed that I had been treating Ebola patients in Sierra Leone, and then I was escorted to the quarantine, CDC unit, and then asked further questions. But that screening process, resulted, I forget, there was an estimate, and I don't remember, but it's a significant amount of money. 30,000 people were screened. 68 people were identified with a fever during that airport screening. 40 of them were referred to healthcare facilities for further examination, and not one of them had Ebola. But just like I had colleagues and friends when they were being monitored for 21 days, sure, you've just flown, for 20 hours in a plane. A lot of people developed an upper respiratory infection or diarrhea or other symptoms. And everyone I know who that happened to, was quite happy to first kind of self-isolate in their own homes. I mean, you understand that these are also people with families, a wife and children. I know a few healthcare workers who actually did choose to not stay with their families when they returned home, because that was just their choice, and I think that's great if it is your choice. But yeah, so if I had developed a fever when I was staying in Maine and Fort Kent with my partner, I would have went into a room and shut the door and called the health department, and we would have gone through the process of me being referred to a facility and having further evaluation. I think that would have been perfectly fine. I think when thinking about that entire process, and I know there's a lot of logistics and all that, right? First you have to think about, okay, how do you get that person safely from their home to the healthcare facility? And if all you have is a mild fever, I would almost argue, I know that health departments really had a lot of debate about this, about sending an ambulance. But if I can get in the car myself with if I'm feeling okay, I just have a mild fever, it would probably be safer for me to get in the car and drive myself to the healthcare facility instead of getting, EMS members involved who don't necessarily understand the PPE and can't safely take care of me. So, these are all, it's really intricate, the kind of detail you have to think about to go through all the steps to try to keep everyone safe. But I would have, of course, wanted to seek medical treatment and see if I did have Ebola or wait it out a few days. And I think with several of my friends that did happen to, they developed a fever and it was just, upper respiratory. They didn't even get tested for Ebola, right? They were just evaluated in a healthcare facility for a few days.
Rosemary?
Rosemary Taylor, Tufts University. I have two questions. One is about the fact that the three countries affected, we refer to them as West Africa, right? But there were actually three separate countries. And they had different legacies from the past with three different countries. And I was wondering, I thought the film was tremendous. I was wondering, Greg, if you saw distinct differences between what happened in Liberia because of that and, let's say, what happened in Sierra Leone. And then the other question concerns healthcare practices. I mean, the one thing that I thought wasn't entirely clear in the film is that it was clear that healthcare was going on before the arrival of the international community. And a lot was made about the problems of burial teams of coming in and grabbing bodies and not being sensitive to body washing practices, etc. And in addition, the other controversy that occurred, I can't remember now if it was in Sierra Leone, I think it was between Partners in Health and MSF about hydration and what was the best way to go. And I was just wondering how that played out in Liberia, because there's an interesting book by Paul Richards on, which you probably know, on Sierra Leone, how the community itself, and in terms of dealing with the medical people who were on the ground, sort of dealt with care, because it wasn't as though, yes, there was no cure, but things could be done, and which practices did they adopt and why?
Yeah, I mean, I think one of the things that you saw so clearly in the international response was the way in which each of the countries, Guinea, Sierra Leone, and Liberia, were depending on, a former colonial situation. I mean, Liberia is, technically not a colony of the United States, but in essence, it was a neo-colony. And so, I think that was one of the challenges for Liberia, was to try and, who did they go to internationally, right? I mean, MSF was, correct me if I'm wrong, but I think MSF was more present in Sierra Leone and Guinea than in Liberia, at least initially, which has kind of the historical context, right, in terms of both French and then British colonies. So you did see that different, and so Sirleaf made that, a specific appeal to Obama, right, to try and mobilize that long kind of U.S. connection in trying to get aid and support. And I think it was a little slower coming in that context. In terms of the healthcare workers and things that they took up, the whole international attention around burial practices, as though somehow this was mysterious. Or I was talking to a New York Times reporter at the time, and she brought this up about all these weird cultural practices of washing bodies. I'm like, what's so weird about that? I said, when my father died, it was very important for me and my mother to wash his body. I'm like, that's part of the healing process of death. Like, there's nothing, some kind of exoticism here, right? But it was the way in which people kind of jumped on that as, really pushing the spread. In terms of the response, I mean, Randy mentioned, I mean, there was a lot of improvisation on the ground. A very famous nurse that developed a PPE unit that from garbage bags and never became effective. So there was a real effort to develop, kind of appropriate technology responses on the ground by Liberian healthcare workers in the face of that. So.
I will just add that, the healthcare systems in these three countries were pretty much non-existent. I mean, sure, there were some hospitals and healthcare facilities, but probably the kind of place that you would walk in and there weren't actually any drugs available, there weren't actually gloves available. I mean, these, particularly, I know about Sierra Leone more than the others, but it looks like Liberia is much, very similar in terms of, chronic war. So, I think the capacity was already quite limited. But just to remind everyone that the other outbreaks of Ebola were in Central Africa, right, in kind of the DRC region. In fact, DRC that now has an outbreak, this is their 10th Ebola outbreak. But there had never been an Ebola outbreak in Sierra Leone, Liberia, and Guinea. So, there was also a limitation of knowledge, when your country has actually never seen this disease before.
So I know there are a number of questions left in the audience, but there's also a reception outside, and there's plenty of time to ask our panelists questions there. I'm sorry to leave the questions there. I know there's a lot more we can talk about. There will be further discussion later tonight and tomorrow, but please join me in thanking both of our panelists for a remarkable presentation.